So how do we approach a small fiber neuropathy? The practical aspects I'll be trying to cover here. First of all, what are small nerve fibers? We should understand what are the small nerve fibers and how they are different from the large nerve fibers. If you look at the nerve fibers, they are of large and the small. Those fibers which are thickly myelinated contribute to a larger size of them because of the myelin sheet encircling them. These are the large nerve fibers. Those which are smaller are normally very thinly myelinated, or they are unmyelinated. So these large nerve fibers, as we know, they are responsible for a faster conduction because of the greater abundance of the myelin in them. So these are the A alpha and the A beta fibers. They are responsible for muscle control and also through the large fiber sensations like the vibration, position perception, and touch. The small nerve fibers are either unmyelinated or thinly myelinated. They are responsible mainly for the nociceptive sensation and also the temperature. Nociceptive is the pain and also the temperature, that is the warmth and the cold sensation. One more important thing is that the small unmyelinated nerve fibers or the thinly myelinated fibers, they contribute to the autonomic nervous system. The autonomic nervous system, the A delta fibers and the C fibers. The A delta contribute to the preganglionic autonomic nerve fibers, whereas the C fibers contribute to the postganglionic autonomic nervous system. So these are, they have a role in the nociceptive, temperature control, as well as the autonomic functions. So the same thing which I told, the A alpha and the A beta are the fastest conducting fibers because of the abundance of the myelin in them. They transmit the impulses at a very high speed. That is, they are normally more than 36 meters per second, the velocity. Whereas these small fibers, the lesser the myelin, lesser the speed. Therefore, the C fibers is at 0.4 to 2.8 meters per second, whereas the A delta fibers is from 4 to 36 meters per second. Then, as I told, they have a lot of role in the nociception, the pain perception. So the pain intensity, actually we have just understanding the physiology. There are two types of pain. One is the first pain and the second pain. The first pain is mainly by the faster conducting fibers, that is A alpha, A beta, and the A delta. They mainly provide some information regarding an immediate threat of a sensory information so that we can withdraw immediately. Whereas the second pain attracts longer lasting attention. So it causes some behavioral changes and cortical adjustments to limit further injury. So these first pain and second pain are, this is a rapid high amplitude pain. This C fiber is a constant continuous low amplitude pain. So understanding this physiology just based upon the conduction velocity and the size of the nerve fibers and their functions, we go ahead to how these small nerve fibers look. That is a histopathology. If you look at a nerve fiber, as we know, there are multiple nerve fibers which are encircled in a fascicle, which group together to form a fascicle. So each nerve fiber is encircled by an endoneurium, and multiple fascicles are bound by a perineurium with a feeding blood vessel, and all the fascicles are clumped together by an epineurium. So this is a cross section of a nerve in a nerve biopsy on hematoxylin and eosin stain. So if you blow up this picture, for example, this is a cat equine nerve. Equine sciatic nerve, which is shown here. You can see that these are the large myelinated fibers which have got a myelin ring around them. These bare spaces which do not have any myelin sheath, these spaces are occupied by the unmyelinated nerve fibers. Here again, this is a blown up image where the myelinated fibers are very well seen, but the unmyelinated fibers are present just in between the myelin fibers and they are very barely seen. They look only like some connective tissue. They're not very easily visible. So how do we identify the myelin? It's by the Kapal stain, and we find that the myelin takes up this chain and it appears like black rings, ovoid rings around the axons. But these thinly myelinated, in the spaces in between, you can see certain thinly myelinated fibers, but you can't appreciate their architecture. And unmyelinated fibers are barely seen. So what I want to highlight here is the myelinated fibers can be easily picked up on a nerve biopsy, but the unmyelinated fibers and the small myelinated, very thinly myelinated fibers are very, very difficult to appreciate on a routine nerve biopsy. They require certain specialized techniques. One is electron microscopy, but on the electron microscopy on a day-to-day basis, it is not practical. This is an electron microscope view where you find that there is an axon. It is encircled by multiple lamellae of myelin, which this is an example of a myelinated nerve fiber. But if you see on the right side, you can see that there is a nucleus of a Schwann cell, and this is a Schwann cell. you can see, which is encircling multiple axons, the bare axons, and it shows no interest in producing any myelin around it. So this is the architecture of a unmyelinated nerve fiber with a Schwann cell. This is called a Remark bundle, where each Schwann cell encircles multiple unmyelinated nerve fibers. So to say these, to highlight here, these unmyelinated nerve fibers are like bare roots which can creep virtually to every organ, or here you can see it is creeping in between the crevices of the rocks. Like that, these unmyelinated nerve fibers can virtually creep through every tissue, and it innervates the heart, the various visceral organs, and also the blood vessels, and it's got a role in the autonomic functioning, and it also creeps onto the skin to form the epidermal nerve fibers. These are the dermal nerve fibers, and it creeps to the skin to take care of the nociceptive sensations as well as the autonomic nerve functions. So they spread over different regions of the body. If you look at the large nerve fibers, they have a well-defined organized receptors, sensory receptors, like you have a Merkel disc, Ruffini organ, Pacinian organ, and a Meissner's corpuscles for their sensory modalities. But A delta and the C fibers, majority of the time, they are nothing but the bare nerve endings. So these are the bare nerve endings to take care of their respective sensations and supply it to the central part. So what are the other techniques? I told that routinely on a nerve biopsy, it cannot be picked up. So how can we identify? The advantage is that the skin is very easily accessible, and it is thickly innervated by the epidermal and the dermal nerve fibers. So there is a technique called the bright field microscopy. From a skin punch biopsy, you can check even by the hematoxylin eosins chain also, but you have to immune stain the epidermal nerve fibers. So the protein PGP 9.5 is a protein which is present on the epidermal nerve fibers. So you can immune stain these epidermal nerve fibers, and you can identify these epidermal and the dermal nerve fibers. One of the technique is a bright field microscopy, which I will be elaborating here to identify these small nerve fibers. Here, this is a normal biopsy, skin biopsy. Here you are able to see these dermal nerve fibers. These dermal nerve fibers, and this is a epidermis, and this is a dermoepidermal junction. So once they cross the dermoepidermal junction, the continuity will be maintained, and they lose their thin myelin sheet also once they go into the epidermis. So once they travel from the dermis to epidermis, they lose their myelin sheet. Here you can see the abundancy and continuity of the epidermal nerve fibers. If you look here, which is an example of a small fiber neuropathy, you can see that there is hardly one dermal nerve fiber which is crossing into the epidermis. So there is a paucity of the small nerve fibers in this section. Here you can also see that it not only fails to cross the dermoepidermal junction, it also forms certain axonal swellings just proximal to the dermoepidermal junction. So here, this is a pre-degenerative stage of a small nerve fiber neuropathy. Even in the dermis, the epidermal nerve fibers are very, very fragmented and broken down. So these are some of the changes which can be appreciated on a bright field microscopy using specialized technique. This is again a bright field microscopy where you can appreciate these are the sweat glands. They are thickly innervated by the nerve fibers. However, in a patient with small fiber neuropathy, there is a lack of encirclement by the small nerve fibers, suggestive of a small fiber neuropathy. So this is the basic histopathology and some of the advanced techniques to identify the small nerve fibers. Now, what happens if there is any pathology of the small nerve fibers? What are the clinical manifestations? We all know, having understood that physiology, the large nerve fibers mainly take care of the pressure, the vibration, and the joint position sense, whereas the small nerve fibers are mainly responsible for the pain and the temperature sensation and the autonomic functioning. So in the absence of these small nerve fibers, the sensations would be either positive or negative sensations. The extreme positive sensations could be in the form of burning sensation, hyperpathia, or it can be allodynia. We all know that allodynia is for a non-noxious stimulus also. They find extreme pain, or it appears very painful, or it appears like the patient might complain that there is a wrinkle in the sock which never goes away, or there could be some small pebbles in the shoes. So these are some of the complaints they present with. We all know that large fiber sensations are mainly associated with deep aching, crampy pain. They are associated with areflexia. But the small fibers, they don't take care of the reflex arc. That is why it is not necessary to have areflexia. They have distal sensory complaints. Areflexia need not be there in a pure small fiber neuropathy. and they do not contribute show much interest in the conductions, because we all know that the conductions is mainly by the large nerve fibers. So you can also have a normal nerve conduction. However, in large fiber neuropathy, you have an impaired nerve conduction velocities. And the small fiber neuropathy, because of these trophic changes, because of the severe pain and all, it impairs the quality of life and it contributes to increased morbidity and also mortality. Why? Because it is a part of a cardiovascular autonomic neuropathy. It also predicts the bad cardiovascular outcome, and sometimes it might contribute to the mortality. Whereas the large fiber mainly takes care of the proprioception. So there is an increased risk of sensory ataxia. Because of the sensory ataxia, there is an increased risk of falls and fracture. So this is the difference between large fiber neuropathy and small fiber neuropathy. Now this small fiber neuropathy can be again of two types. One is a length dependent small fiber neuropathy, or it can be a non-length dependent small fiber neuropathy. As I told you, the length dependent small fiber neuropathy, it mainly affects distally, and we all know that it progresses upwards like a stocking and a glove pattern. Once it reaches a knee, it goes till the tip of the fingers, and once it reaches a thigh, it goes into the this one wrist, or it can be the intraumbilical tent-like loss of sensation in the abdomen. The complaints are again like a length-dependent neuropathy, starting from the bottom and progressing proximally. But if we see the non-length dependent small fiber neuropathy, the symptoms are much more widespread. The patients might give some complaints that they cannot perceive hot and cold sensation while showering and while taking a shower. Or it can be some focal mononeuropathies. They may not have any distal sensory loss, but they can have focal mononeuropathies, like say meralgia parasthetica. Though it is described as an entrapment neuropathy, lot of interest and lot of advances are there, and the symptoms resemble a small fiber neuropathy. So focal mononeuropathies are also contributed by a small fiber neuropathy. So even some burning mouth syndrome, perioral paresthesia, severe perioral paresthesia or midline sensory complaints are all can be seen with a small fiber neuropathy. So these symptoms are much more widespread, and it is probably immune mediated. Like if you check the length dependent neuropathy, probably you see in diabetes or alcoholics as a length dependent neuropathy. But if you see the non-length dependent neuropathy, some of the common causes are Sjogren's and some connective tissue disorders and like sarcoid, etc. So probably they're immune mediated. So this is the, like if at all you have a non-length dependent, better chase for some immune markers, or whether they are steroid responsive should be strongly contemplated. After finishing this somatic complaints, that is both length dependent, non-length dependent, now the other functioning, as I told you, is the autonomic neuropathy. So what are the manifestations in the autonomic neuropathy? They can, as I showed you in that slide, they can innervate virtually every organ of the body. So the manifestations are very diffuse. So the cardiovascular complaints, it can be central, it can be something to do with the orthostatic failure of the regulation of both the heart rate and the blood pressure, or during the supine position, they can have resting tachycardia, and it might also contribute to the intraoperative and perioperative cardiovascular instability. One important thing is they present with chronic fatigue-like syndrome with decreased exercise intolerance because of the failure of the cardiovascular system. The other complaints are the gastrointestinal. So if you look at the gastrointestinal complaints, there could be esophageal dysmotility. They can also have gastroparesis diabeticurium. This is patients with diabetes who have this autonomic failure. They can have early satiety and easy bloating because of the decreased motility of the intestine. They can have explosive nocturnal diarrhea. They have to wake up multiple times in the night, and they have explosive diarrhea, with watery diarrhea, and that might contribute to some amount of dehydration and constipation and fecal incontinence. The genitourinary complaints are they can have erectile dysfunction and female sexual dysfunction, and also neurogenic bladder and cystopathy, which is regularly seen. And the other complaints are, as I told you, is a failure of the sweat regulation, the pseudomotor function, with anhidrosis or hyperhidrosis, heat intolerance, gustatory sweating, and dry skin. And the pupillary fibers can also be affected, where there could be pseudo-Agile-Robertson pupil, and there is a failure of the pupil to contract or relax on exposure to the light changes. That will lead to some symptoms of blurring of vision. So these are the protean manifestations of autonomic neuropathy. Now, what are the investigations to identify small fiber neuropathy? First of all, it's elusive. So if you look at the reflexes, sometimes it can be preserved, though you have distal small fiber neuropathy. On electrophysiology also, because they don't contribute much to the nerve conductions. Sural conductions also might be normal. And even on routine nerve biopsy, I showed that on routine biopsy, then prone to be missed because they are something present in the inter nerve fibers in between the myelinated fibers, and they're prone to miss. So some modification of the nerve conduction technique can be done by using ring electrodes, and you try to obtain the conductions from the medial and the lateral digital plantar nerves. So we are trying to move a bit distally to elicit the conductions. So here we have placed the ring electrode, and you can obtain the medial and the lateral digital plantar nerves, which are branches of the tibial nerve. However, this is technically difficult, and sometimes because of the technical reasons also, the conductions may be normal. Because of the technical reasons, the conductions may be absent. The other one is, instead of the sural, where we stimulate very proximally, we can go for the dorsal-sural, where the electrodes are placed very close to the little toe. Okay, so these are some of the techniques which are tried to increase the yield of the nerve conduction study in a patient with suspected small fiber neuropathy. However, the gold standard technique is a skin biopsy. The skin punch biopsy is very easy technique. Here you can see that this is a skin punch biopsy needle. This is available. It's actually very cheap. It hardly costs less than 100 rupees. And the diameter can be 3 mm, 4 mm. It's available. This punch biopsy can be used to take a tissue. A punch of the tissue can be excised from the area of interest. So after infiltration with local anesthetic, you can insert the skin punch biopsy forceps, and you penetrate it, like something like you burr a hole deep, and you can separate it from the underlying tissue, and you can process this skin tissue and analyze the dermal and the epidermal status. The common sites which are used are the calf muscle, 10 centimeters proximal to the lateral malleolus, the proximal thigh, and this is a dorsum of the foot. So this actually does not require any suturing also, just they can use a band-aid, and it's very simple technique. And even during the follow-up also, you can monitor sometimes, like within three weeks, the nerve fibers will regenerate. So you can also follow up the status of the progression. Then once the skin punch biopsy is taken, as I mentioned, there is a particular protein called the PGP 9.5. So this PGP 9.5 can be stained for its antibodies. And here you can see on the routine stains, you have stained with the PGP 9.5, and you can identify the dermal plexus. From there, the branches of this small nerve fiber can be easily identified. There is a other technique by using a slightly sophisticated method, is a confocal microscope, where same, you use the PGP 9.5 protein and immune stain. So this is to identify the epidermal nerve fibers. And the collagen stain is used to identify. It stains green. The collagen is stained green with the collagen staining. So the green is the collagen, and here you can see the epidermal nerve fibers which are stained green, stained red. This is a normal biopsy, but in patient with a HIV who is on drugs and he had small fiber neuropathy, you can see the paucity of the nerve fibers. Small nerve fibers are absent, and only the bare collagen can be seen in this slide. So this intraepidermal nerve fiber density assessment has a sensitivity, very good sensitivity, 90%, and specificity is also 95%. The other technique, which is again non-invasive, unlike the skin biopsy, it's a very simple technique, is a corneal confocal microscopy. We all know that the cornea is richly innervated with nerve fibers, which are branches of the first division of the trigeminal nerve. So here you can see that this is a small, this is the skin biopsy. So these are the corneal, on the surface of the cornea, by using a confocal microscope, you can appreciate the small nerve fibers. So this is almost, studies have shown that it's almost similar to the skin biopsy, a non-invasive modality. And in patients with small fiber neuropathy, here the slide B is showing small fiber neuropathy, where there is a paucity of these small nerve fibers. And similarly, the cornea is also showing paucity of the nerve fibers. However, such a scenario can occur only when there is a diffuse small fiber neuropathy. If it is very focal, say only distal leg, it might not be replicated in the cornea. So after those two tests, which are important, like skin biopsy and the corneal confocal microscopy, the other technique is a quantitative sensory testing. This is more of a functional testing. So you deliver some graded standard sensations. These are the thermal sensation, or the vibratory stimuli and measure the threshold at which an individual can detect such a testing. So where is he able to identify? There are multiple methods, like you can detect the mechanical detection threshold, vibration, cold, heat, warmth, mechanical pain, pressure, and allodynia. So these are the various modalities. You use a graded tuning fork, radial cipher tuning fork, and also monofilaments and pinprick. So these are given in a graded manner and in a very quantitative, measurable manner. So when you apply this gesture on the patient, he will have to tell where he is able to perceive the pain. Normally, if you see here, the cold stimulus was given. So at 12.7, 13.2, and 15.1, you also have to check the replicability of the test. So at what sensation he is able to perceive, whether it is normal. And in case of small fiber neuropathy, there will be a blunting of the sensation. So this is how this quantitative sensory testing is done. In fact, some of the study, this is one study which was done by our professor to check the electrophysiological tests, various electrophysiological tests in patients with small fiber neuropathy who had impaired glucose tolerance. And among them, they found here the skin biopsies were not done. Among the non-invasive testing modality, quantitative sensory test was found to be most sensitive technique for the detection of neuropathy. And among the nerve conductions, as I told you, they are also technically very difficult. The medial digital plantar and the dorsal sural nerves can increase the sensitivity, can add on to your findings of presence of small fiber neuropathy. So then coming to so these are the somatic tests which we have checked. Now coming to the autonomic functions of the small fiber neuropathy. The various autonomic function tests are the cardiovagal, the sympathetic, parasympathetic, and the pseudomotor. As we know, the sympathetic is mainly by it takes the control of the blood pressure, whereas the heart is under an inhibitory cardiovagal tone. So the tests of the cardiac heart rate are mainly parasympathetic. The tests of all the blood pressure are mainly sympathetic. And also one more is a sympathetic skin response, which are routinely practiced. So coming to the parasympathetic test, one is any change in the heart rate with any maneuver you do. So one is the deep breathing, one is the Valsalva ratio, and the other one is to standing. We all, with the deep breathing, what happens is, normally we all know that there is a normal sinus rhythm. With inspiration, there is an increase in the heart rate, and with expiration, there will be a decrease in the heart rate. So with inspiration, there is an increase in the heart rate. That is, there is a decrease in the RR interval. With expiration, there is a reverse decrease in the heart rate and an increase in the RR interval. So we will check the RR interval between the expiration and the inspiration. So if it is reacting well, it is normal. If it is less than a particular value, it suggests it's not reacting. So it is abnormal. Similarly, Valsalva ratio. When the patient is asked to breathe across a closed glottis, initial phase, there will be an increase in there is a decrease in the blood pressure and an increase in the heart rate. After the release of it, then there will be a reverse. So based upon these heart rate values, as well as the blood pressure values, we can identify which limb of the autonomic function is impaired. Similarly, standing. We all know that with standing, there will be an initial decrease in the blood pressure and an increase in the heart rate. So again, here you can take the RR interval and calculate, because this response to standing will rectify in 30 seconds. That is why we have taken 30/15 ratio. So these are some of the tests for the parasympathetic functioning. Then the other tests for the adrenergic, as I told you, the sympathetic function are all blood pressure dependent. So the BP changes to Valsalva maneuver and head up tilt test or active standing. So any BP measurements are indicative of a sympathetic functioning. And the other one which can be used routinely in the bedside is a sustained hand grip. So when the patient is asked to inflate the manometer, sphygmomanometer, and hold it like a sustained hand grip to 1/3 of the maximum contraction he can make for a prolonged period, then you can check the increase in the diastolic blood pressure, whether it is improving or not. The other tests are the quantitative pseudomotor axon reflex test, thermoregulatory sweat test, and the sympathetic skin response. I will just mention very briefly about these tests which are relevant to a small fiber neuropathy. So these are the pseudomotor tests. Pseudomotor, as we know, it's first we have to understand this physiology of an axon reflex. Whenever there is a scratch, the impulses go orthodromically, but they need not reach the axon. They can get bifurcated. They can change their direction near a bifurcation of an axon and go down, and they can stimulate the blood vessels and the sweat glands. So they can be a reflex vasodilatation. This is a normal axon reflex. So this quantitative pseudomotor axon reflex test. So we are making use of the axon reflex and we are quantifying the sweat production. This is indicative of a distal part. So if at all there is a problem proximal to the cell body, the proximal limb, it won't make any difference. So it is much more suggestive of a post-ganglionic autonomic functioning. For example, here, how do you stimulate? It is mainly by using this acetylcholine. It is iontophosphed. There are some, there are some electrodes which contain the chambers filled with acetylcholine. Now this is placed over the forearm. Now by using a stimulation, the acetylcholine is released into the skin. Now this acetylcholine goes and activates very diffusely because it goes at a bifurcation point and diffusely is activating all the postganglionic autonomic fibers. Then you collect the sweat production. It's quantified by a pseudometer that quantifies the sweat production. You can check it near the foot, the distal leg, as well as the proximal leg. So the area, how much quantitatively, how much is the sweat production can be given in the distant sites. This is a quantitative pseudomotor axon reflex test. Okay. The next test is a thermoregulatory sweat test. This thermoregulatory sweat test here, we are checking the sweat production. It's a pseudomotor function. So we are checking the sweat production in the different, in which areas, what is the pattern of the loss or whether it is normal. In giving certain conditions where the patient has to stay in a chamber and the temperatures are all quantified. So he's exposed to a particular graded temperatures and we are quantifying what is the pattern of the sweat production by using the dye. We all know that here alcerin dye is used here. Normally we know that cornstarch reacts with iodine, then you get the change in the color which can be picked up. If you check this thermoregulatory sweat test, these are some of the examples. Here in this patient, there is a normal sweat production and it is slightly variable in intensity, but it's present diffusely. So this is normal. This is a patient with a length dependent neuropathy. So distally in the legs and in the hands, there is no evidence of any sweat production on the thermoregulatory sweat test. This is a patient with a myelopathy. So distally beyond the level of the D9 lesion, which he has, there is no sweat production. And here in this patient, there is a patchy areas of anhydrosis. So this is an area of a truncal radiculopathy. And this is meralgia. This is a anterolateral cutaneous nerve, lateral femoral cutaneous neuropathy. Here, this is in patient with pure autonomic failure, where there is a diffuse postganglionic pseudomotor function is lost. So there is complete anhydrosis, very, very mild patchy islands of sweat are there. So these are the various patterns which can be quantified with a thermoregulatory sweat test. The other one which can be easily done in the electrophysiology lab is a sympathetic skin response. So here, this is based upon a startle response. When a patient is given, it's sort of an evoked potential. So when a patient is given a sudden startle, it can be a galvanic stimulation with a small electrical stimulus, or it can be a tap, a sudden unexpected pat on the back, or it can be simple with a knee hammer if you tap over the sternum, or it could be a sudden sound. So all these are the stimuli. So they evoke a response. That is called the sympathetic skin response. Here we don't quantify much, whether just present or absent is what is quantified in the sympathetic skin response. It's an evoked response. It takes time. So the sweep is normally very high. It's 1 second. If you don't get in one area, you can check in the other areas. And the problem, because it's a startle response, it gets habituated. So repeatedly you do, maybe you will not get, it gets habituated and it might be absent. So this is a sympathetic skin response. Sympathetic, therefore it checks because the postganglionic fibers are normally sympathetic and they are cholinergic. And the sudden startle will activate the sympathetic system. So to summarize, these are the tests of which are used in electrophysiology lab. These are the tests for the parasympathetic function and the sympathetic function. So as I told, anything to deal with the heart rate is a test for a parasympathetic innervation. Anything to do with the blood pressure are tests for sympathetic dysfunction. And sympathetic skin response, because of a sudden startle which activates the sympathetic unit, is again a test for sympathetic dysfunction. The other test, which is very easy to do, which can be used in pediatric and uncooperative patients and at the bedside, is a skin wrinkling test. Here, the patient is asked to submerge his or her hands at 40 degrees centigrade for 10 minutes. And we can check whether the wrinkling is present or absent. The normal wrinkling is suggestive of an intact sensory nerve fibers. So this is a skin wrinkling test. The other sophisticated test is a contact heat evoked potential. Again, this is an evoked potential. Various heat stimuli are given, and the patient should and the evoked potentials are obtained from a CZ electrode. So, however, all said, there are a mixture of a simple test as well as a complex test. The thermoregulatory sweat test and also the contact heat evoked potential. All these require special laser equipment for the contact heat evoked potential and microneurography. These are all complex or sophisticated tests. So, however, simple things are still the best. So, you don't require any complex equipment. But if you are strongly suspecting a small fiber neuropathy, when the conditions are normal, you have to go step ahead and you have to check the orthostatic blood pressure, if there is a fall in the blood pressure on standing, and whether it is recovering. So these simple things or the simple tests are still very, very relevant in a diagnosis of a small fiber neuropathy. Now, having understood the investigations, what are the common causes of small fiber neuropathy? The most common cause, as we all know, is diabetic small fiber neuropathy. So how do these patients with diabetic small fiber neuropathy present? The symptoms are, there are severe burning pains in the distal foot. They're so severe sometimes they can be associated with some vasomotor changes like redness and blunting of the pain and the temperature. They don't allow even some air from the fan to get and touch their foot, and they don't let even the blankets cover the foot. So they might use a bed cradle to give some spacing in between the clothes and the leg or the foot. And because if you see, isolated small fiber neuropathy is very rare. Normally, there might be some combination of a large fiber neuropathy superimposed also. But in the early stages, they can have pure small fiber neuropathy when the long tract signs or the large fiber signs might be intact. So they can have relative preservation of the vibration and the position sense. They have impairment of the small fiber sensations. And even the pseudomotor function, that is the sweating, might be abnormal. They can have autonomic neuropathy, and we all know that small fibers produce a lot of trophic factors to the skin. So there might be trophic changes in legs, like dry. The legs might be dry, or there can be shiny, and there can be hair loss and sweating abnormality. So these are some of the common scenario how we find a patient with a diabetic small fiber neuropathy with uncontrolled diabetes. But in due course of time, there can be progression to involve the large fibers. The other condition where you find a small fiber neuropathy in patients with diabetes is impaired glucose tolerance. Say you have a patient with diabetes, patient who comes to you presenting with small fiber neuropathy, but his sugar levels, he says they are normal. You check the fasting post lunch, they are normal, but they can have impaired glucose tolerance. So you have to chase for the glycated hemoglobin or the glucose tolerance test in them. In fact, these glucose tolerance tests might become abnormal even within 6 months to 1 year. So it's something like a premonitory stage, or it's a pre-diabetic stage, which you have to chase and identify. This is again a rapidly reversible hyperglycemic neuropathy. This affects the acute, it's very acute condition, and it affects the small fiber nerves. One thing is that in this impaired glucose tolerance test, they have associated autonomic symptoms also. They can have diabetic cachexia, they can have weight loss, depression, and autonomic dysfunction like erectile dysfunction, and they can have acute worsening of retinopathy also. So these are some of the features. They can have normal nocturnal exacerbations, and the examination might be normal except for allodynia and absent ankle jerk. This is a self-limited condition. This is similar to the insulin neuritis. It's actually not an inflammation. It's probably an insulin neuropathy, where in patients who are instituted insulin treatment for very high blood sugars, and suddenly the sugars come back to normal, they could have acute painful neuropathy. Again, this is again a self-limited condition which improves within 3 to 8 months. So this is because of an abrupt control of increased blood glucose. If the glycated hemoglobin in a patient newly diagnosed, young male, he's been newly diagnosed with diabetes, and aggressively the control has occurred, and the glycated hemoglobin falls by 2 to 3% in 3 months. So greater the dynamic drops, there is more severe symptoms. So within 2 to 6 weeks of continued glycemic control, the symptoms recover. So I will just go through one case scenario about a 13-year-old boy. He had diabetes of 3-year duration. He was on insulin therapy. He came with 1-year history of polyuria and nocturia. He has to wake up multiple times, and there was some neurogenic bladder. That is, he was able to feel the bladder sensation. He can void normally, but it was associated with poor stream and dribbling, and he was not able to empty bladder completely. There was residual urine. So this patient had, on examination, even the cremasteric reflex was intact. The reflexes all, even the ankle jerk was normal. Sensory long fiber sensations were intact, but there is some small fiber evidence. He complained of loss of blunting of the pain and the temperature below the lower third of leg. Even the perianal sensations are intact, ruling out a myelopathy. Plantar were flexor. So he was referred from the nephrology, and micturating MCUG also showed it was clearly evidence of neurogenic bladder with significant post-void residue. The investigations were done. The glycated hemoglobin was high. He had 3 years history of sugar, diabetes in a young patient. The rest of the values were normal. Ultrasound abdomen showed hydronephrosis with some reflex nephropathy. So this was the MRI, which was normal. The conductions was done. Even the conductions were normal. Our lab cutoff is 8. It was only 7.9. Velocities, everything was normal. So only positive features were his symptoms, neurogenic bladder, and the blunting of pain sensation in the distal, blunting of some of the sensations in the distal part of the leg. So, however, when we checked the pupils were dilated and they were not reacting to light. He was standing, walking, and his reflexes, pupillary reflex was one thing which we could pick up. So when we have done the autonomic function test, we found that there are some impairment of the heart rate variability, which is suggestive parasympathetic dysfunction. So this was a patient who had diabetic small fiber neuropathy and autonomic neuropathy. Because it's a small fiber neuropathy, it is missed on the routine conductions, and we had to focus on an autonomic function test in order to identify. And the other one also in the clinical examination, you can check for the pupillary responses which were absent in him, in addition to the neurogenic bladder which we had. So the other entity which you commonly see is a Hansen's disease, which we all know that Hansen's is a disease of small nerve fibers. The Mycobacterium leprae has got a predilection to the Schwann cells, and it causes neuropathy, particularly the small fiber neuropathy, and it requires cooler temperature for growth, and it targets the skin, the cranial and the peripheral nerves at superficial location. The testis, it can cause orchitis, and also the anterior third of the eye. So it has a predilection towards the cooler areas of the face. So you have to check for the rash. What are the common sites of the rash? These are over the face, that is the pinnae of the ears, and it can be over the nose and the malar areas, the abdomen, central abdomen, and the buttocks, and also over the hands and the feet distally, which are the cooler areas. But the warmer areas like the axillary, inguinal, and the inguinal folds, the popliteal fossa, and the perineum are spared, which are relatively warm. We all know that they can have skin patches. In case of tuberculoid leprosy and lepromatous leprosy, depending upon the body's response to control the inflammation, whether it is trying to cluster it in one area, it's a tuberculoid leprosy. In lepromatous leprosy, it's a severe disease where the bacilli can grow wherever it wants. So there is no effort to control this infection. So these are the two variants. And we look for the thickened nerves. As we all know, here we have a patient with the greater auricular nerve, which is very prominent. Similarly, the areas which we have to look for thickening of the nerve is the supraorbital ridges, the greater auricular nerve, the cervical nerves, the median, and also the ulna near the olecranon fossa, the radial nerve at times in the spiral groove, the cutaneous branch of the radial nerve near the styloid process. We all know common peroneal nerve routinely palpated near the neck of the fibula, and the posterior tibial nerve just behind the medial malleolus. So when you palpate, there can be tinal sign, and the nerve will not only be thickened, but you can appreciate a beaded appearance, and it will be tender. In case of lepromatous leprosy, as I told you, it tends to produce multiple skin nodules. There can be mudrosis and prominent supraciliary arches, which give a leonine faces, but with advent, it's not very common these days. And the WHO classification, it's mainly important in deciding the therapy, based upon the skin lesions, whether they are paucibacillary, which are less than 5 lesions, or multibacillary, if it is more than 6 lesions, to determine whether you have to give the therapy for what duration. So as I told you, the Mycobacterium leprae, through the receptors like laminin and collagen, it targets the Schwann cells first. So it is mainly a demyelinating neuropathy initially, particularly in lepromatous leprosy also. First, it damages the Schwann cells. Then there could be axonal damage as a part of the reactive granuloma formation. And sometimes this is a tuberculoid leprosy, the slide on the left, and this is a lepromatous leprosy. Here in tuberculoid leprosy, there is a lot of inflammation. So the endoneurial inflammation is very, very severe, and it can also form granulomas. This is a lepromatous leprosy where there can be foamy histiocytes with the leprobacilli, which is scavenged or intracellularly within the macrophages. One of the emerging modality, which is non-invasive, is the ultrasound. So the high resolution ultrasound of the nerves can easily identify whether the vascular architecture is disrupted or not. And it is of very importance in differentiating the other differentials, particularly in the presence of mononeuropathy and when it's a pure neurotic, where the skin lesions are absent. So here we can see some, this is an ulnar abscess, this is a cross-sectional, and this is a longitudinal one. You can appreciate some beaded appearance, and even on the Doppler, you can appreciate some blood flow, suggestive of a leprous abscess in the ulnar nerve. So these are the two conditions. One is diabetes, which is most common, and alcoholism as well. Alcoholism is also one common cause, and the other one is a Hansen's neuritis, which we have discussed. Next, I will like to go through one case scenario. This is a 32-year-old female. She had complaints of numbness, dysesthesia, and burning paresthesia in both hands and feet of 2.5 years duration. She had cramps in the calf region and distal muscle weakness in both the upper and the lower limbs. She had a lot of autonomic symptoms like gastrointestinal. She had early satiety, nausea, vomitings, and frequent loose stools and fecal incontinence and excessive dryness of mouth. And bladder also, she had neurogenic bladder. So she had autonomic symptoms as well as a length-dependent neuropathy and severe pain. There was history of consanguinity in the parents, and father died at 32 years of age, and there was severe autonomic symptoms. Even the sister had died at 18 years with a sudden cardiac arrest. So there was some family history, and she had autonomic symptoms. On examination, she had a non-healing ulcer over the left foot. The pulse was 86 per minute. The blood pressure in the supine was 120 and standing was 100/70. The fundus was all normal, and in the motor examination, there was hypotonia, and the reflexes were absent in the knee and the ankle, and the plantars were flexor. The sensory examination showed graded length-dependent sensory loss, and the vibration also was diminished in the toes. Now, this patient, she had a nerve conductions which was suggestive of sensory motor axonal neuropathy, and autonomic function test was also abnormal. Then, because of the large fiber involvement was also there, the nerve biopsy was done, which was showing acellular eosinophilic material in the endoneurium, which was positive for the Congo red staining. So this is a eosinophilic material which was positive with the Congo red, and it showed apple green birefringence under polarized microscope, which is suggestive of a amyloid neuropathy with a family history. Actually, we don't have a clear report. It was sent by the patient, and this genetic analysis showed mutation in the exon 3 transthyretin gene, which is likely pathogenic, which is suggestive of a hereditary amyloidosis. So we have variants of the amyloidosis, and amyloidosis is also one of the cause for small fiber neuropathy, but it's a rare cause where the patients can have a lot of autonomic symptoms and small fiber neuropathy. The other thing which we routinely find in our OP practice is the segmental sweating abnormality. This was a patient who presented with hyperhidrosis. He complained that in the hot climates, he will have sweating only as a segment in the back of the trunk. Whereas the above and below that particular segment, there is no abnormality which he perceived. So this patient, when he worked up for the causes, he had subtle autonomic symptoms. He didn't have any other abnormality. Conductions were normal. And when we worked up for the cause, anti-Rho-La antibodies were positive, and he was diagnosed as Sjogren's, and he responded very well to the IVIG followed by maintenance therapy. So this is a patient with Sjogren's. One thing, if we go back, compared to the length-dependent neuropathy, which is seen in diabetes and alcoholism and the other etiologies, this, if at all you have a non-length dependent pattern, suspect immune conditions, immune-mediated neuropathies. So search for Sjogren's or sometimes sarcoid, or Sjogren's should be one cause which has to be contemplated by checking for the markers as well as for the lip biopsy. and the Schirmer's chest to check for the tri-eyes. Now, this was another patient. Now, this patient came to us. He had a complaint of hyperhidrosis. He said that there was sweating only on the left half of the face and the trunk. He was 17-year-old, and he had no other complaints. He was embarrassed with this, that's all. He did not have other dysautonomic symptoms. So when we applied Constarch with povidone iodine, so it was changed both the sides of the face. And when he was asked to stay for some time in a hot region, hot place, there was sweating only on the left half of the face, whereas the right half did not show any color change on the Constarch iodide test. That was normal Constarch powder which is available, and the povidone iodine which is routinely available. So there was no sweating on the right half of the face. Actually, here the abnormality is in the right half of the face, which is anhydrotic. The left side is producing normal sweat. So this was also present in the trunk. So this is a rare cause of a segmental sweating abnormality. These are some of the rare enigmatic cause. This is a patient with Ross syndrome. Actually, when this patient, again, he had a tonic adis pupil. Tonic adis pupil. You can see the left side, it is reacting well, the pupil, whereas on the right side, it is sluggishly reacting. And when we checked the H reflex, conductions were totally normal, but the H reflex was absent. So this is a rare syndrome, postulated to be due to some small fiber genetic abnormality, something like a body habitus, where he had sweating abnormality, tonic adis pupil, and areflexia. And we also have to think of some other familial causes of autonomic neuropathy and small fiber neuropathy, which we encounter in the clinical practice. See, this was a child. She had her tooth removed because of repeated self-mutilation. She had damage to her tongue as well as the lip, and the tooth was removed by a dental consultation to prevent further self-mutilation episodes. We can also see that there is a corneal haziness, corneal ulcer. So she was not bothered about the injury. There was no pain in her eyes, and for which tarsorrhaphy was done. Actually, they have this repeated self-mutilation, and dental damage can occur both because of the self-mutilation episode, as well as they have a lot of reflex abnormality. Reflex esophagitis can be there, which cause damage to the tooth. And these are the calluses which he had over the hand. And there is some amount of self-mutilation which can be seen on the right hand compared to the left. And there are also calluses, and she was not bothered about the pain. So as we all know, this is a patient with hereditary sensory and autonomic neuropathy. So there are 5 variants, and mostly it is due to the genetic mutation and the tyrosine kinase receptor. Actually, the tyrosine kinase receptor, it's a nerve growth factor. The nerve growth factors are required for the normal nerve growth. Now, in this patient, there is a mutation in this nerve growth factor receptor. When the receptor is not formed, they won't take the nerve growth factors from which are being supplied to this, and thereby they degenerate. So this is one of the cause for the hereditary sensory autonomic neuropathy, which is a familial cause of neuropathy in addition to the familial amyloidosis. Coming to the other miscellaneous causes, we all know the metabolic causes. Even vitamin B12 deficiency can cause painful neuropathy. It can cause neuropathy in addition to the proprioceptive loss as a part of subacute combined degeneration. One more I told about diabetes as well as impaired glucose tolerance also. Similarly, even dyslipidemia, hypertriglyceridemia is also implicated in small fiber neuropathy. Even patients with metabolic syndrome, their intraepidermal nerve fiber density is very low. Thyroid is one which you have to check for the presence of small fiber neuropathy, and chronic renal disease. So we know the Gopalan's burning feet syndrome, where the patients have severe pain in the night in their feet, similar to the diabetic small fiber neuropathy, which is of multifactorial. This is a patient, he was an alcoholic, he had chronic liver disease, probably some amount of malnutrition could be coexistent with that, contributing to the small fiber neuropathy. He had trophic changes and severe pain, he complained. He's a chronic alcoholic. He came for the psychiatric consultation for the de-addiction, and he had severe painful small fiber neuropathy. Positive signs were there. So these are the changes where you can appreciate the shiny skin with some distal toe deformities. The other infections we all know is HIV. One infection is the HIV. It can be because of the infection per se or because of the drugs, antiretrovirals like protease inhibitors and diadenosine, which can cause small fiber neuropathy. Similarly, hepatitis C. Hepatitis C, 1/3 of the patients can have cryoglobulinemia, and this cryoglobulinic vasculitis is also one of the example of a small fiber neuropathy. Influenza or post-influenza immune-mediated small fiber neuropathy. Antibiotics, the common one are fluoroquinolones, which you use, metronidazole, nitrofurantoin for the urine infections. So all of them can cause small fiber neuropathy. Chemotherapy, oxaliplatin, the platinum group of drugs, can also cause severe small fiber neuropathy. In fact, they cause painful small fiber neuropathy. Sometimes it can worsen with a cold, which is reverse. Normally, these small fiber neuropathies, they worsen with exposure. They're relieved by cold. People complain that they are better by using some ice cubes. So in oxaliplatin, it's reverse of it. So they are worsened with the cold exposure. Statins are also known to cause some small fiber neuropathy, and vitamin B6 toxicity. Though it causes ganglionopathy, it can also cause some sensory neuropathy in doses more than 100 mg per day, which is used in case of refractory seizures. The other immune-mediated diseases are, I told about a patient who had Sjogren's. Similarly, sarcoid, rheumatoid arthritis, particularly if they are on TNF-alpha inhibitors. You have to check for celiac disease, again autoimmune mediated, other vasculitis, and paraneoplastic. Paraneoplastic anti-HU antibodies can cause both sensory and autonomic neuropathy. Anti-CV2 CRMP5 can cause sensory and motor neuropathy. So these are all the secondary causes of neuropathy. And 50% of the small fiber neuropathy, we don't have any cause, whether they're idiopathic. But a lot of active research is going in this idiopathic cause, whether we can identify any immune responsive condition or any primary condition. So what are these advances in the small fiber neuropathy? Before we go, I would like to tell about this primary small fiber neuropathy. Recently, of late, they found that in the patients who had erythromelalgia, they were found to have the sodium gene mutation. It's the channelopathy. So what is erythromelalgia? The patients with small fiber neuropathy, even it was seen even in children and adults. So these patients, they have sudden episodes of flushing and severe pain in their limbs, and the conditions may be normal. They have small fiber neuropathy. It's very, very painful. It is believed that there is an arteriovenous shunting in the skin surface. So once, because of the capillary redistribution to the surface of the skin, the nerves are prone to ischemia, something like a steel phenomenon. So these nerves tend to have severe pain at that time. So this is an inherited erythro and melalgia. So severe pain with redness. And they can also be, one more thing, small fibers, I highlighted pain, temperature, but they also take care of the itch sensation. So this patient also had severe itching. This is taken from the textbook. This patient also had severe itching and cirrhosis. So they can have severe dryness and episodic painful crisis. And recently they were found that there is a lot of mutations. It's a channelopathy and it's a sodium channel mutation where the sodium channels are hyperexcitable and a lot of calcium goes inside the axon. And this is causing some amount of small fiber damage. So what are the other advances in small fiber neuropathy? Whatever idiopathic and non-specific, any painful syndrome, there is a curiosity whether there is a component of small fiber neuropathy. Fibromyalgia, previously it was thought to be a non-specific pain disorder or a rheumatological condition with polymyalgia rheumatica. 50% of the patients are found to have reduced intraepidermal nerve fiber density. Even the restless leg syndrome, where they have severe dysesthesia during night time, there is a speculation whether it is a component of small fiber neuropathy. Post-herpetal neuralgia, the regional pain syndromes like CRPD, all of them, where there is flushing and where there is severe painful episodes. Even Ehlers-Danlos syndrome, they have hypermobility as well as some painful episodes. Even POTS, postural orthostatic tachycardia syndrome, it's said to have a small fiber neuropathy in the form of autonomic neuropathy. It was found that patients with Parkinson's, already we know that there is some autonomic postganglionic autonomic dysfunction in Parkinson's disease. Even in motor neuron disease, actually even in motor neuron disease, even in the clinical practice, we see that they complain a lot of pains. They give a lot of sensory complaints as if it is a sensory motor neuropathy. But when you do the nerve conduction studies, they also give that there is an area of sensory loss also, objectively also they give. But when we do the nerve conductions, it will be totally normal, confirming the diagnosis of MND. But there is a speculation whether there is a component of small fiber neuropathy in patients with motor neuron disease. In fact, there was a search on one of the study has tried to check for the autoantibodies, and there was some autoantibodies like TSHDS, some trisulfated heparin disaccharide, and fibroblast growth factor receptors, which are found in the patients with small fiber neuropathy. However, right now, to say that it is a causative, we don't have further evidence. Probably they have a role in the pathophysiology. They are probably associated. Probably fibromyalgia is associated with small fiber neuropathy, but it's probably not causative as of now. There is also a literature search for there is also a search for an apparent autoimmune basis for this small fiber neuropathy. There were some studies which tried to give IVIG for such severe pains of small fiber neuropathy. They concluded that some of the studies have concluded that there is class 4 evidence that IVIG is safe and effective for small fiber neuropathy with an apparent autoimmune causality. However, to conclude, the IVIG is not still effective. We can't use it in routine practice. This was an article which got published in 2018. But as of now, we don't have enough backup from the literature in idiopathic small fiber neuropathy. But if you are suspecting an immune mediated, it is definitely useful in a non-length dependent neuropathy. So being a COVID era, I think COVID has got all the manifestations related to neurological syndromes. So similarly in small fiber neuropathy also, there are several reports with small fiber neuropathy after 2 months of COVID infection. The symptoms were very acute and skin biopsy also, documented the decrease in the intraepidermal nerve fiber density. And this COVID infection associated small fiber neuropathy, also they documented that they did not respond well to symptomatic treatment. There was a case report which suggested 1 week after receiving second dose of COVID-19 vaccine, probably this is immune mediated because they mentioned that they responded very well to immunotherapy. So probably this vaccine is immune mediated and the COVID infection is probably direct toxic or whatever. The reports mentioned that, and there is a speculation for the role of IVIG in the COVID-19 associated neuropathy. So to summarize, the small fiber neuropathy presents with somatic complaints, pain, and autonomic symptoms. The pain, it can be primary pain syndrome like erythromelalgia and paroxysmal pain syndrome, or it can be small fiber mediated painful neuropathy, which is a wide spectrum. There is a speculation whether it has got any role in fibromyalgia, in fatigue, chronic fatigue syndrome, in GI symptoms, and cognitive dysfunction, chronic fatigue and chronic low performance, and cramps and restless leg syndrome. And autonomic symptoms also, a host of autonomic symptoms can be caused by small fiber neuropathy. So to roughly summarize, what are the blood tests? If you find a patient who gives complaints of small fiber neuropathy, conductions would be normal. You should try to chase the autonomic functions with the orthostatic drop. Pupil should be examined and get the autonomic functioning test also, both clinically as well as functions on electrophysiology. Check for the glycated hemoglobin in addition to the sugar values. Oral glucose tolerance test is a must. It might be a pre-monitoring, it could be a premonitory phase of a diabetic stage. Thyroid, CKD, HIV along with its drugs, hepatitis C serology for cryoglobulinemia, ESR, sarcoid, and all the vasculitic profile, particularly in a non-length dependent small fiber neuropathy, celiac disease, and serum electrophoresis and light chain disease for amyloidosis and paraproteinemia, vitamin B12, and one of the other inherited condition is a Fabry's disease. And also statins can cause, as well as hyperlipidemia also can cause. And genetic testing for the mutations and also trans-13 mutation. Imaging, if at all you are suspecting sarcoid or in case of amyloidosis. And tissue biopsy for this lip biopsy for Sjogren's. And nerve biopsy is generally not performed unless there is large fiber involvement. So nerve conduction study, if it is abnormal, it is large fiber neuropathy. If it is normal, check skin biopsy and quantitative sensory testing. If it is abnormal, investigate for causes of small fiber neuropathy. If no cause, it is idiopathic, which can be 50%, and lot of active research to chase this idiopathic small fiber neuropathy. So what is mentioned is there's a lot of active research going on to chase this idiopathic small fiber neuropathy and to come down on the percentage from 50% to find out the etiology, whether it is immune mediated or whether it is familial with a genetic cause. So small fiber neuropathy causes different symptoms in different people at different times. So it can cause orthostatic drop, it can cause chronic fatigue, which are some. And manifestations are protean. Some of them might be going to a dermatologist for the xerosis and erythromelalgia, rheumatology with joint pains, fibromyalgia, gastroenterology with GI discomfort, and cardiology with some heart rate issues. So the manifestations are protean, and there is a need for unifying neuropathy and finding out the etiology. That's it. With this, I would like to conclude my talk. So the entire things in a nutshell is small fiber neuropathy is pain, temperature, and autonomic. That's all. No vibration and proprioception in a pure small fiber neuropathy, but normally it coexists with the other large fiber neuropathy. Diagnosis is missed in a routine nerve conductions. Autonomic test should be done either clinically, bedside test, or on the electrophysiology. Skin biopsy is a gold standard to prove it. Non-length dependent search for immune responsive entity. And it's the current area of active research. So with this, I wish all a happy Teachers' Day and conclude my talk.
Thank you, Sireesha. It was a wonderful, extensive lecture on small fiber neuropathy. So we have a few questions. So let's go to a few questions. So first one is, when would you consider non-diabetes differentials for autonomic neuropathy in patients with concomitant diabetes? So if you think that patient has diabetes and small fiber neuropathy, do you, you automatically attribute it to diabetes, or is there a red flag to say that something else may be also be there?
Yeah. See, one thing is diabetes, long-standing diabetes, it is associated with small fiber neuropathy and coexistent autonomic neuropathy. The symptoms could be overlapping. The problem is with the type 1 diabetes, autoimmune type 1 diabetes can coexist with an autoimmune autonomic neuropathy. So that has to be changed. Diabetes without small fiber neuropathy, the autonomic neuropathy does not occur. But if a patient has directly autonomic symptoms without any symptoms of small fiber neuropathy, so no symptoms of small fiber neuropathy, his complaints are only the autonomic symptoms, then probably you should think of other autoimmune conditions. That is one. And secondly, this is actually, it's better to exclude the other causes since before concluding it as diabetes, where you only control the sugars, whether there is an immune responsive element, we have to consider. As I told, the non-length dependent neuropathy, if at all it's a non-length dependent autoimmune functions, consider immune responsive entities. So we have to chase in that line. So what I mean to say is, diabetes without small fiber neuropathy, autonomic symptoms don't occur.
Okay, so let's put it another way. So when you see a small fiber neuropathy, what is your first line of, for example, it's for a residence purpose, when they sit in the OPD and see a first case of a small fiber neuropathy, without any reasonably, they can clinically exclude a large fiber neuropathy, reflex are normal, posterior column is normal, and power is normal. So what are the first line of investigation they should do, or they should do a blanket AK-47 and shoot everything? So how do you go stepwise? First line, what should you do, and what should you, how should you go for the second line?
First of all, if a patient comes with normal examination, some mild pain, temperature, we should be very careful not to say that it could be functional. We have to chase further. So the test-wise, the simple bedside test, that's what I am highlighting. Simple bedside tests like autonomic symptoms, pupils should be examined, which are very distal to the site of complaint. Pupil should be examined because in the case which we found, it was a pupil was not responding at all. So autonomic bedside test as well as an autonomic function test should help. Once you have documented some autonomic dysfunction, start with the common causes first. One is diabetes, then impaired glucose tolerance. So check for the glycated hemoglobin and also the oral glucose tolerance test. Then only go for the other immune vasculitic profile. And then based upon the family history, the complex test. So it can be done in a graded manner. You can't have any blanket test for any neurological condition. And also B12 and other nutritive causes also should be checked.
Okay, now, so the next question was, in your clinical practice, how commonly you see different subtypes of amyloidosis, like AL amyloidosis, especially when the family history negative cases? Maybe specifically asked about acquired amyloidosis, like AL or onset amyloidosis? How frequently we see, as probably in relation to small fiber neuropathy?
Yeah, all said and done, amyloidosis is very, very rare. It is not a common cause. We had only that patient as a rare patient with familial amyloidosis with a positive family history. But otherwise, even in paraproteinemic conditions also, maybe we have seen 2 cases. That's it. It's not a common. Maybe you should add to the experience from the other centers.
Yeah, so it depends upon you. Usually the cases go to the hematologist and medical oncologist. Usually we get cases from there. So the thing is that whether it is amyloidosis or diabetes, before anyone with having a distal sensory symptoms should not be immediately labeled into having neuropathies. So we had a patient who has been treated as paraproteinemia related neuropathy for close to 3 months by big centers. Finally, when you examine the patient, his tone is increased, plantar is bilateral extensor, mild sensory symptoms, and she had CNS involvement of a Waldenström macroglobulinemia. She was a known case of Waldenström's. So things are, there's no substitute for clinical examination. If you miss the first step and you assume certain things because patient has got a background history of diabetes or background history of amyloidosis, whatever is there, you may be chasing the wrong lane. You have chose the wrong road from the beginning itself, and you will miss the thing. So someone else has commented on dorsal sural and medial plantar. How dorsal sural and medial plantar, which are large fiber studies, evaluate small fiber neuropathy, or do you have lab standard for dorsal sural nerves?
Routinely, we don't do the dorsal sural nerve conduction. In case of small fiber neuropathy, as I told, in the conductions it might be missed. So we are going distally. So it is just near the little toe, which we do the dorsal sural nerve conductions. And medial plantar, see the tibial nerve, as it passes through the tarsal tunnel, it divides into the medial and the lateral digital plantar nerves, which supply the sole of the foot. So the medial plantar nerve, we use ring electrodes near the big toe. Lateral plantar nerve we use a ring electrodes near the little toe, and we try to get the conduction. The problem is, again, these are technically very, very small, thin nerves, and you have to stimulate. And technically, they might be absent technically. If you get it, well and good. If it is absent, we don't know whether it is a technical reason or whether it is a true tarsal tunnel syndrome, which can mimic a small fiber neuropathy, or is it small fiber neuropathy? So
I think the question was whether because the question is framed like that, whether these are actually large fiber nerves, whether they actually contain small fibers to evaluate whether if there is abnormal, can you say it is a small fiber neuropathy, or still they are part of a large fiber only? That's a dorsal sural or a medial plantar nerve. I think that was the question. I think.
Yeah, the terminal twigs of these are small fibers. So they are still mentioned as small fiber neuropathy. They can be abnormal and small fiber neuropathy. Okay. And
another question was, how do you differentiate central and peripheral autonomic dysfunction?
Yeah, the central, yes, to identify the central autonomic dysfunction clinically, they have non-specific complaints like chronic fatigue and all. The peripheral autonomic dysfunction can have, could be parasympathetic or sympathetic. Isolated limb involvement also might be there. So the investigations wise, yes, for the central and peripheral, one is, as I told, QSAT does not take into consideration the central limb. It bifurcates near the axon, and it doesn't take into consideration. It does not require the central component of the autonomic function. So that can help to identify the peripheral pure autonomic failure. There is also a mention of this cardiac MIBG scan, particularly MSA and PD also. The cardiac scans as well as adrenal MIBG scan, adrenal scans can help to differentiate the central and peripheral autonomic failure.
More questions, I think we can type the answer in the question answer section. I think it's already 11:45. We can go into the next session.